This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of prehospital care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs-bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, I'm speaking about reframing resuscitation, termination to withdrawal of life support with Darren Braude. So out-of-hospital cardiac arrest remains one of the most emotionally complex and ethically challenging events in prehospital care. It's true to say that families can transition from normality to absolutely devastating loss within minutes, whilst clinicians must also make rapid, high-stakes decisions that often last and have emotional impact. So traditionally, EMS practice is centered on the moment of termination of resuscitation, a clinical decision that often results in abrupt death notification and limited family involvement. But there's a growing body of work challenging this model, suggesting that it might cause an unintentional amplification of trauma for both families and providers. So in today's episode, we're joined by Dr. Darren Braude. He's a paramedic, director of the Centre of Prehospital Resuscitation and ECMO. He's also the chief of the Division of Prehospital, Austere and Disaster Medicine. Dr. Braude is one of the leading voices behind a powerful reframing, really around viewing the end of resuscitation efforts, not as termination, but as the withdrawal of life support. So, borrowing principles from ICU end-of-life care, this approach centres around families, promotes clearer communication, and acknowledges CPR and ventilation are themselves forms of life support. So today, with Darren, we're going to explore how this model can transform the way EMS navigates death, grief, and humanity in the field. Welcome to the podcast, Darren.
Thank you for having me, especially to talk about a topic I'm very passionate about.
Absolutely. And let's just dig into it, actually. So we will publish a paper which you have yourself published. We'll put it in the show notes so people can go away and read that, because I think it frames the conversation quite nicely around the shift from termination of resuscitation to withdrawal of life support and that reframing. And if I could get you to speak to that, just really, why that matters for both families and clinicians.
Well, I mean, as you set the stage, I mean, this is a very devastating, moment for people, but not just for the family and loved ones, but for the providers that are involved with this care. And we know the burden that has on all of us in this business. And I think that piece shouldn't be neglected either. So I think it's important that we do, like in everything we do, we should do the best we possibly can for our patients and their families and for our providers. And I think, as people that are engaged in resuscitation, we often like to focus on the resuscitation piece, but at a certain point in many of these cases, we realize that we've shifted and now we're resuscitating the family and not the patient.
Yeah, indeed. No, indeed. And, your piece is a fantastic read. And really, to your point, actually, Darren, around bringing families on the journey, because, you say this in the piece, around death notification can be sometimes extremely traumatic and not expected for families, but bringing them in earlier around the ongoing, on that journey of resuscitation and hopefully realigning, giving them warning shots and realigning their expectations on that journey so that the final message isn't necessarily as traumatic for them. Could I get you to sort of speak to that?
Well, and I think, and I like how you refer to that as a journey or a process, but it's definitely should be more than a moment. And I mean, sometimes we have no choice, right? But when we have that choice, and I do think that perhaps we could have done a better job in the paper of emphasizing that this is not in and of itself about family presence through an entire resuscitation. And I mean, I hope we can, talk more about that. And I certainly support that when it can be done appropriately. But this is really, as you said, about engaging family early and and then having them when appropriate there at that final moment of closure. They may or may not be engaged physically during other parts of the resuscitation, but I think that, um, as you said, this is life support. Um, and we would never withdraw life support in the ICU while a family is out at lunch, right? I mean, it would just be inconceivable that, of course, you would want to have the family present at such a pivotal moment. And, but throughout so much of my career, this was just kind of the family was there. We're in the back room doing what we're doing. They don't know what we're doing. We don't know what they're doing or thinking. And then there's just this moment of just kind of dumping this incredible, devastating news on the family and and seeing how I feel like there's a lot of things we do much better in the field than in the hospital. And but we need to also see what we can do better at the hospital and bring to the field. And that's something where I feel like we're starting to navigate that intersection better.
Yeah, indeed. And you mentioned in the piece, and it really does sort of form a cornerstone of practice, which is allowing family members to be present on not only on that journey, but certainly within resuscitation efforts. I get the case vignette within the paper you mentioned, Darren, is really around the EMS team continuing resuscitation to allow the parent time to arrive and witness the efforts. And could I get you to really speak to how common this approach is in real world practice, and maybe if it's not done, how much of a deficit that can have on the family.
Well, and this vignette, I mean, this is a case that we had. And as you mentioned, that was a unique case in that we did continue a resuscitation with basic life support measures to allow um, the mother to arrive on scene in consultation with the father, her husband, to make the best decision. I don't think that's common in the field. It's certainly not in our system. I don't think it's uncommon in the ICU to say, there's somebody flying in from, and we need to see if we can keep somebody supported to let somebody arrive if we can do that appropriately. Um, but it is about recognizing that what we said earlier, it's about when does the resuscitation shift from resuscitating the patient? Um, when does when does the patient really become the family and the loved ones? And in the case like that, it was obvious from the first moment that we were not going to be able to save this patient, but how do we do the best we possibly can for the family in that moment?
Yeah, absolutely. And the paper denotes this quite nicely. But could I really get you to unpack maybe just some of the barriers um, that can occur, the logistical, the emotional, the cultural barriers to offering a family presence during the resuscitation in the pre-hospital environment? Because to your point, I very much within my own practice made a point of not, if there was a remoteness to the family member, not delivering as much as possible, not delivering a death notification message over the phone, because if they have to drive, yeah, I would just say, look, you do need to be here if that's feasible, if it's not hours and hours, or even if it is, just come in as promptly as you can. But being respectful that there is barriers but it's try how you navigate those barriers to bring family to the patient side as much as possible. Could I get you to speak to those barriers and maybe mitigation of those?
Absolutely. And I think just to back up and set the stage here, so when I'm referring to this concept of withdrawal of life support and using the analogy to a hospital-based and often ICU practice or more of a hospice-based practice. I mean, what we're saying for the pre-hospital setting here is we're doing a resuscitation and we, those resuscitations can go one of two ways. They can end up in a transport to the hospital in a small proportion of cases in most systems, or in a majority of cases in most systems, we're going to end the resuscitation, what we would call termination of resuscitation. Some places there's a pronouncement of death there, some places there's not. That's kind of a important legal semantics. But to me, what I'm trying to say is at the point that we stop compression, stop breathing for a patient, that is equivalent to turning off a ventilator in the ICU. And where it's appropriate, I want to have family there at that moment. And we've built rapport with them. We've established relationships with these kind of warning shots you refer to and they may or may not be present through that whole resuscitation or parts of it until the end. But if you're going to have family present during resuscitation, and I think that there's some listeners in the pre-hospital space that are hearing this and they're like, well, of course we do that. We've done that forever. And then there's probably colleagues that are listening to this going like, why would we do that? We never do that. That sounds very uncomfortable. And I think those are the barriers that you're referring to. So we're talking to our colleagues that are coming from that, that perspective, which is totally appropriate. I mean, and that was somewhere I was in my practice for, honestly, for decades. I thought that was the only way this was done. And when we started bringing family in, even in the emergency department, there were just endless barriers that were presented and reasons not to do this. And I think it's a bit of human nature. We're good at creating reasons not to do things that seem hard, right? I mean, anybody have a teenager, right? I mean, they're the experts at coming up with reasons not to do things that seem hard. I would, there's not physical space. Well, that may be true. I mean, we do resuscitations in back bedrooms, but often there is space, or maybe a little window of space, or maybe we can actually move the patient, as we did in the vignette, into a space specific for the family. It's like, oh, we can't move a dead body. Well, wait a second. They're a patient right now. We can move a patient to do a resuscitation if that's important. There's nobody to explain to the family what's going on. Well, that may or may not be true, and I understand that's a limitation, but we have colleagues I mean, I work a lot in rural areas. I have and continue and live in a rural area where, one or two providers, you show up on scene and we've done family presence for years just because we know everybody. We know the patient, we know the family, but who's going to keep them away? So and so they don't have somebody explaining it to them, but there's also that important note. If I show up on a scene and I like, this is an ECMO candidate, that's not the one where we're trying to figure out like how to bring somebody in. It's where it's a very different case. And once you kind of shift to family focused care, sometimes you can free up somebody that might otherwise be critical to a resuscitation. It's too hard for the family to see what's going on. We hear that all the time, which may be true for some family members, absolutely. But I think we also have evidence that it's hard for family not to see what's going on. Um, I think people are concerned that they're not going to do a job for the patient if they're being watched. And I appreciate that, but I also think that that comes back to first of all, we're being watched all the time. You're being watched on the streets all the time. But again, it's the shift. I mean, are you really in the middle of trying to manage a critical airway and the airway is going to determine the outcome of the patient? That may not be where we want somebody looking over our shoulder. But where are we in this resuscitation and process? I think especially for the American audience, there's I'm going to get sued, the legal concerns, which have not been borne out at all. And I think there's as much legal risk of having families imagine what you're doing, or more importantly, what you're not doing for their loved ones, than actually when they see it. And then I hear that it's too hard emotionally on me as a provider. And I have a lot of appreciation and respect, especially for that piece. But um, I, th I think that we have evidence that these cases without family are already devastating for the providers, that this may actually make it oddly better for the providers in the long run.
Yeah, indeed, indeed. And the piece goes a long way, really. The article, again, we'll put it in the show notes to really describe translating some of these concepts from the ICU into maybe a more chaotic pre-hospital environment. And but to your point, actually, Darren, there is you just have to see things differently. There is off ramps and mitigation strategies to bring others and indeed families along on that journey, and almost replicate the ICU in the hospital environment, despite it being chaotic. And to your point, that it might not be perfect, there might be certain special circumstances where it's not appropriate. But could I get you to really maybe unpack really some of these central concepts from ICU, like you said, warning shots, bringing the family along, actually maybe deconstructing language, just this is the breathing pipe that's through the, and actually bringing this, not losing the family in overt medical terms or indeed, and but also giving them giving a pause to assimilate information, to really understand the gravity of information, to slowly shift and realign expectations so that that last that last message isn't necessarily such a devastating one. But all these concepts really from the ICU, where you have this nice controlled environment, and you are bringing them on that journey.
Yeah, I mean, and I think you stated a lot of those concepts well. And I think it's interesting when we talk about the chaotic environment. I think we are, if we're comparing an active resuscitation in the field to a patient who's been in the ICU for weeks, and now we're getting to brain death determination, and we've brought the family together, then that is apples and oranges. I would agree with you. I don't think we can still learn from that, but that is a different scenario. But I also think we would, as pre-hospital clinicians, would agree that our resuscitations in the field are often less chaotic than resuscitations in the hospital. And so I I do understand that when we talk about the chaotic environment, we just have to think about where in that phase of resuscitation are we? And we're trying to talk about moving, you know, compressing days of an experience for a family into minutes effectively, and that is a challenge. But anybody who has, when I talk about and teach death notification, which is, and I was teaching death notification before this concept was evolving. Um, the idea, if you walk outside, and whether this is in the emergency department, the ICU, or in the field, if you walk out to where family is positioned and cannot see a resuscitation for whatever reason, and you have to just walk out and drop that bomb. I mean, everybody who's done that, just the feeling in your gut walking out there. This is what a lot of our law enforcement and military colleagues have to do all the time. And you just, it's, nobody wants to do that. When you get even one chance to interact with a family member and give them some warning shot and develop just the slightest bit of rapport over 5 minutes, even before you drop that bomb, it feels different. And it's amazing how, if you can have two interactions before the final interaction over 10 minutes, again, it feels each one of those, it's like an exponential pressure relief valve in some respect. And so that's that's what I'm trying to replicate in the field, and just kind of take this big timeline of, in the ICU, you have rounds and you see people multiple times over yeah, we don't have that, but we can replicate a piece of that.
So the paper really does a nice job at really approaching some of these frameworks and mnemonics actually. And so let's just look at some of the frameworks and mnemonics because to your point, I think even if you can institute 10-15% of some of these principles, it's iteratively better for the family and indeed hopefully for the providers. But so let's just look at the walls framework and in reducing that burden. And so the paper denotes all these, and you'll see them in the paper. But could I get you to speak to the walls framework?
So for the listener, that's the withdrawal of life support framework. And do you mean specifically like the mnemonic around that, or which piece of that?
Yeah, indeed. So just around reducing the moral distress, and indeed just aligning with patient goals, bringing the family in, so that there's the in a way there isn't necessarily an inappropriate or misaligned resuscitation that the providers feel like they are, to your point earlier around maybe just doing basic life support. But I've been in situations like this where by there is a semblance of stage 4 cancer, and what is appropriate is basic life support, is not advanced life support. But and then that gives because there is maybe a denial in the from the significant other that this was going to be the end case, but that actually we're aligning what might be an appropriate resuscitation, an appropriate ceiling of care for the crew with this clinical situation, and coming to I guess in a way a predefined outcome, but which brings the family along rather than going all the way to advanced life support and maybe that the inappropriateness of that.
Yeah, and that's I mean that's a an important, that is almost a whole nother paper and discussion in and of itself that's obviously tied into this. And I'm glad you referenced the idea of the moral distress that has been noted in providers when they feel there's not an alignment of what they think is appropriate and what family thinks is appropriate. And that, I mean, that certainly ties into this whole concept. I mean, but there's a bigger piece of that. I mean, I think we need to have guidelines and medical oversight that supports early termination of resuscitation when futile, and doesn't just mandate that every resuscitation has to be the same amount of time and these kind of arbitrary cutoffs, which sometimes might be appropriate, but sometimes not. I think allowing the a verbal DNR from family is super important. And we do in our system allow, to some extent, the providers to honor a verbal DNR and sometimes to engage medical control by phone. And I realize that's, for international, there's lots of providers listening in lots of different places where it might look very different. And I think the idea of supporting a patient's advanced directives over family requests that might that gets tricky, and we always have to also think about provider safety in all of those moments. But the moral distress, I mean, I think this providers, I mean, we all go into this business because we want to do right by people, and but we also want to do right by the family, and I think this is a chance to align those two things. And I think if you haven't sat and cried with a family member at after one of these terminations, withdrawal of life support, if you haven't had that experience as a provider, um, then I'm concerned that we've let our system squash your humanity. And it may, for those listening who haven't had that experience, you may think, I don't want that experience. That sounds terrible. But who has more burnout? EMS providers or an ICU provider or a hospice provider, right? I mean, a lot of people with burnout go into hospice and palliative care. It's actually an amazingly cathartic, healthy experience that makes you Um, I relish, in a way, weird way, I relish those moments where I feel like I've had enough connection with a family and have been able to do connect with them in this horrible moment that they feel comfortable and look to us to say like they want to give you a hug. They want to sit. I mean, I've absolutely, sat on the floor and cried with somebody. And um, but that doesn't, to me, and that may not be the same for everybody, that doesn't create more burnout for me. That's what makes me come back the next day and say, wow, even in a horrible moment when I couldn't save somebody, I could help somebody else. Um, so I think that moral distress, and I think that, um, I think that so much of this is about, it's when we shift from what we can't save the patient, like we said before. What can we do for the loved ones? But in turn, what can we do for ourselves? And it's amazing how often those two things com coincide more than we realize.
Yeah, indeed. No, indeed. And it's been a common theme actually throughout the podcast and around sort of sharing humanity, being a human first in the room actually. Um, but Darren, could I get you to, so there's a couple of other concepts we'll walk through before we look at maybe the PTSD aspect
Mm.
of pre-hospital care. But one would be the witness mnemonic. And could I get you to really just unpack the witness mnemonic for listeners?
Yeah, and this is a great opportunity also to appreciate my co-authors in this particular paper, Dr. Mike DiFilippo, Dr. Naomi George, Paramedic Captain Robert Laprise, and Dr. Pruitt. Um, and some of these folks in particular, Captain Laprise and I have been on this journey together for a long time. Um, and Dr. DiFilippo came on board as one of our EMS fellows, and he was really instrumental behind um, the mnemonic and figuring out how to create that mnemonic and use AI to help create that mnemonic, which is something that's an old dog like me is not as familiar with. But the idea is, and there's other mnemonics around death notification that are very, very good, and that grieving and spikes that some of which, like all of these things, have more applicability or less applicability in certain environments. But our mnemonic here is about, this is specifically about family presence when you feel it is appropriate. And that may be, again, early in a resuscitation, the whole resuscitation, it may be near the end of a resuscitation. But the W is to warn early, and we've kind of alluded that, is let people know those warning shots of where things are at. Still give hope where it's appropriate to have some space for hope. Um, and but let people know that how critical this is early. The I is to invite gently, and it's offering when you think it's appropriate to offer the presence, never insist on the presence. Um, Talk clearly, and you mentioned language. Spend a lot of time when I'm talking about death notification on language and being empathetic, but also you have to be careful of just, we talk about these cliche terms. And, one thing I think is always interesting, and like the one thing everybody learns in EMS training, at least in the States, is, and death notification, the one thing they know is say the patient died. Don't use a euphemism for died. And I think we've maybe missed more messaging in that, because that maybe that's too harsh a language in certain circumstances. Maybe there is a place not to say something like that. We want to be clear. We want to be honest. We want to, the N is now normalizing emotions, understanding what they're going through, validating that. And look, this is horrible. And some family members in a situation like this like to be able to observe what we're doing, and some family members don't. And just, to let them know that that's all emotional, that's the validation. The E is explaining what's happening and what's going to happen. S is support. And this is really there's a lot packed into this one, and I'll come back to that. And the final S is scene coordination and working with the other providers on that are there. But the presence, so, and this is about allowing touch and contact. And so, and there's a lot of, I don't want to suggest that I'm giving anybody, telling people how things should work in their system or giving legal advice in any way. And every system, you have to have these conversations. What we found out in our system, having good discussions and actually sitting down with the medical investigator and team and talking about these things and realizing, so first of all, we don't want to in any way impact the investigation that our colleagues have to do, right? That would be, that's not good for our colleagues. It's not good for the patient and family either. But we also know, really, we mostly know what's a suspicious death and what's not. And in fact, our law enforcement colleagues, I find, often look to us to tell them if it's a suspicious death or not. And that's so, I mean, if you're in a situation where you know that there's an important investigation to happen here, then of course that's going to frame our approach. But what we've found is that our law enforcement colleagues want to support families too. They just, they, they understand our domain and their domain. And what we've discovered is this kind of the workaround, the semantics here is at the moment that we stop resuscitation, and in some systems that may be the pronouncement of death, it may not be. That's when, in our system at least, we transition from patient to decedent, and we go from our patient to their patient, and it's not really a patient, their subject. Um, and up until the point that we do that, we're in control of the scene. And we have to respect that after, they're in control of the scene. Now, we still support them afterwards, and they support us before. And but one of the things we've discovered is that we could bring a family member in where appropriate, and we don't think we're impacting an investigation to gently be able to touch a family member, kiss a family member one last time, um, see them, talk to them before we withdraw life support and terminate resuscitation, and explain to them in advance that once we do that, we're going to have to turn this situation over to our law enforcement colleagues, and they have different rules to protect your loved one. And it's amazing how smooth that's been in most cases. And it's also interesting to me how often in these non-suspicious cases, law enforcement, we go through all this time explaining to the family, look, as once we stop, you're going to have to step away. And then I'm amazed how often the law enforcement's like, oh no, it's fine. It's fine. No, they're good. Because they see what's happening. Their job is more stressful than our job. They want to have some nice closure with families too. So, and that's going to be different if every provider and every system. I'm not suggesting that that's in any way uniform, but um, when I say the touch part there, that's what we're talking about. Um, and then there's also the touch we have between us and patient's family, which I think is also no pun intended, a touchy subject for a lot of people, and I think that's a lot of cultural issues in that and a lot of issues between individuals. Um, you know, um, I think some people have been told like they can't touch people, and in some cultures that would like, why would you say that? Like we hug and we touch everybody, and so it's very interesting to talk to different people and say how does that work? But um, I think it would be a shame not to shake somebody's hand, hug somebody, touch them if you gauge that that's what they need and want, if you can do that in a appropriate manner and let them
Yeah.
drive the process.
No, listen, I agree with that. And I think to your earlier point around semantics, th they are important because I think there is a certain semblance of the family remember everything about that day. They'll certainly remember the way they felt. There might be specific, giving them specifics may not be remembered, but the tonality, the intonation, the way things are said and the way things are phrased needs to be needs to be caring and passing the duty of care or the protection of their loved one onto another service like the police is absolutely the right phraseology. But to your point around not forgetting to be the human in the room, and also to your point, if a 79-year-old lady needs or a family member needs a hug because her husband has died of stage 4 cancer, then that's and you've delivered the death notification message. That's exactly the right thing to do. And they reach forward for a hug. That's exactly being the human in the room. To your point, actually, is exactly the place to be. Darren, you've the article discusses frameworks like grieving, which is quite well known, and you've mentioned spikes as well. But to your point, how well, from your anecdotal experience and it may be borne out in the literature, how well do these translate into practice? Because absolutely, when in the freneticism of pre-hospital care, and especially when people are subsumed by the technicalities of intubation or cannulation or knowing where you are in the whole in the grand scheme, some of these mnemonics can not necessarily be front of mind. But could I get you to maybe speak to, whether they translate into reality, the concept like the grieving or the spikes mnemonic?
Yeah, I mean, any mnemonic, um, it's a framework that can't be strictly applied. Um, but I mean, the grieving mnemonic has done a tremendous amount to support. Just having a mnemonic helps people realize there's something to learn here and create workshops and lectures and talks around this idea of not just death notification, but breaking bad news. There's other bad news. I mean, let's be honest, there's certain circumstances where you might have a family member that's been struggling on hospice for years, and there's some relief in the death in their passing. It's still emotional, but there's some relief, and there might be some other news that you might tell people that might be worse in a way. So it's about bad news and recognizing that. I don't think that our mnemonic, any mnemonic, can be applied across across all settings. Um, it's great just to remind yourself for education. And I do think, when I started teaching checklists, I remember for like airway, I remember telling people, look, this isn't to be applied in the real world. This is just to practice in this situation so you learn the steps. And then I started being like, oh no, actually, you should probably use this in the real world. And so, but I don't think you want to, you might take out a checklist when you're doing medication facilitated airway. I don't know that you want to walk up with a checklist to a family member as you're doing this death notification, but you might if you haven't done this before, or you might want to just have something written down just to remind yourself of what those steps are. But I don't think it's fair to expect any of these to apply in any environment, especially in our pre-hospital environment. But some of it is just it's good. It's really like many cases, it's common sense when you think about it. It just sometimes we just need somebody else to put that down. The one thing in the grieving though that I do a little bit differently is this idea that verify, and this idea that clearly stating the person has died. And I think circling back to that, I mean, I'm amazed also if you include family member in a resuscitation early, you probably have this experience, how often they tell you that it's time to stop. And and that takes a huge burden off us as providers. It's like they're like, no, no, they wouldn't want this. It's time to stop. It's like, wow, okay. Um, that's powerful. But if you have a family member who's there and you've briefed them on stuff, and they're maybe the one telling you to stop or whatever. You're like, when we stop life support, and they turn to you and go, are they gone? I think it's okay to say, yes, they're gone. I don't feel like, because I've heard providers who, with the best of intentions, are like, yes, they're dead. And they took a class somewhere that said, you don't want somebody to have some euphemism like, they've moved on. What, they moved on to the hospital? And I get it. But if they're there and you're engaged with them, you know that they know. And I don't know that you have to be so blunt. I've seen it a couple times play out. It's almost comical. Like, they're dead. You got that part, right? You understand they're dead. I'm like,
Yeah, I know. Listen, I agree, and I think this is the subtle nuance of reading the room and reading the appropriateness of the language. And yeah, absolutely, and this is the beauty of pre-hospital care. It's understanding what is appropriate and reasonable, and bringing the family along on the journey. Um, Sometimes being explicit, but you don't always have to be explicit. Sometimes it's implicitly known and just in the inference. Absolutely. Um, just
I just want to say, reading the room. I mean, I couldn't have said it better.
yeah, indeed. No, indeed, indeed. Just you've talked earlier actually, Darren, about the working in conjunction with law enforcement and absolutely. It's a team effort and that transferal of care and of protection to law enforcement once the life support is maybe withdrawn and to your point as well, that doesn't mean care isn't withdrawn because care can still be afforded to the family and indeed to the patient at that point, but there is care across the chain, but that transferal maybe to the police, but. Could I get you to speak to, so just pivoting slightly because I think we've broached that quite nicely, but looking at, you know, not, you said this earlier, not every situation it's appropriate for the family to maybe be involved. Could I get you to speak to maybe some red flags that EMS providers should maybe consider when determining whether it's safe and or beneficial really to include family?
Yeah, I mean, it sounds cliche to say, but you kind of know it when you see it. Um, I I mean, and a lot of this is, sometimes it's unexpected. I mean, sometimes just because people are showing lots of emotion doesn't mean that that's not appropriate. Um, if people are hostile, I think we recognize that that's a very different situation. If there's a lot of intoxication, um, I think we've all been at situations where somebody collapses at some kind of party or event, and we have, literally, 30 intoxicated family members who are fighting amongst themselves. Somebody feels guilty, somebody has a different opinion, somebody thinks somebody's responsible, and I think you walk into that situation, and I think most providers in most systems might look at that and go, I think we're going to do this resuscitation on the way to the hospital. Right? Let's just get out of this situation. And that's totally appropriate. And hopefully our providers are supported to make decisions like that. But I mean, if your sense is that you're unsafe, then then don't do that. But I also think that as you get that, especially like anything, the first time you try something like this, it should be in the optimal situation. And then after your team has done this a few times, you start realizing that there's um, that sometimes it's exactly what people that seem very emotional need and or seem kind of hostile, but not in there's hostile and there's dangerous, right? And there's just oh, you better don't tell me you're stopped. Make sure you're doing everything for, and then it's like, well, why don't you come with me and let's see what we're doing for your loved one. I understand, and it's surprising to me, and it's also it's a luxury to have more providers on scene, and And it is different. I mean, I've been first on scene. I've been in a team of two people on scene, and that's different from in our urban area where we have, 10 people, including supervisors and doctors sometimes. And I mean, you can't translate to all circumstances, but um, I would let people just go with their gut feeling. If this doesn't feel safe, then today's not the day.
Yeah, indeed. No, indeed. Just as we come into land, actually, Darren, a couple more questions. One would be, you've talked about this push-pull nature, and I don't think this necessarily gets enough airtime. And you speak about it in the piece, and it's a fantastic point around really the clinician and, reducing PTSD amongst EMS providers. And so could I get you to maybe really how we mitigate PTSD in and amongst either empirically or indeed experientially from your perspective, we reduce this PTSD from a clinical perspective, from a clinical well-being perspective, because like you quite rightly say, we're always focused on the families. There's not necessarily that mirror to reflect back on whether the clinician carries forward the emotional burden of that resuscitation.
Absolutely. That's so important. Um, I mean, clearly PTSD is multifactorial and individual, and I don't I don't claim to be an expert in the subject matter, and but I'm not sure the people that are experts in the subject matter would say that they can always predict who's going to have issues or not, and what the trigger is for any one provider. But we do have themes, and we have seen, and there's some literature that says the more death notifications you've done in a certain amount of time, the more likely you are to experience um, common metrics of PTSD. And I think that that would make sense, and it ties into our conversation, but it is a much broader topic, of course. I think that if um, if we know that this is emotionally taxing for providers, then it makes sense to try to figure out how to mitigate some of that. And I think the evidence, and some of it is a lot, a lot of, and then some of it is subjective and anecdotal. But if providers feel supported, educated on how to do this, even if it is, I mean, I understand. I mean, it may just be in some cases a death notification that we may not be able to translate all that I'm talking about today, and that's okay. Um, but it's educating providers on how to do this. I think there's so much value to role playing when you're practicing this. I teach death notification to a lot of our paramedic students, and I role play it out for them, so that they don't feel uncomfortable, and I act out the role in evolution. I mean, the way I normally teach this is I come in and give an example of a terrible death notification that I've seen, and then I tell them, like, what would you do differently? And we just keep building it, and I keep doing it, and I'm emotionally exhausted at the end of every one of these sessions. But I think role playing and then asking them in their training, when, like, how often do paramedic students, like, you do a mega code, you do cardiac section, and you do a mega code, and at some point the preceptor, the proctor says, okay, done. Whether that's you're done with the resuscitation, the patient's dead, or you're like, it's like, no, but I actually encourage them to actually practice taking this through in the classroom, in the simulation lab, and practicing that is so important. And I think that if we give people education, we empower them to include family when they feel it's appropriate, and give them the space to be a human, like we talked about. Um, and it's okay to be emotional, and it's okay all that. I think there's a little bit of objective evidence, but I think there's a lot of anecdotal evidence that for most providers, and I'm not going to say it applies to everybody, but for most providers, that's going to help them come back to work the next day.
Yeah, absolutely. I really agree with that, actually, Darren. So just to finish off, really, just looking at family-centered withdrawal of life support as a model, and is indeed, to your point, as training and indeed policy development and interagency working, because again, to your point, role playing with even with a semblance of someone else role playing the police and how you integrate the police and or another agency into, because that mimics real life and mimics actually what happens in real clinical practice. But could I get you to speak to really the next steps for EMS systems wanting to adopt family-centered withdrawal of life support models?
Uh, well, I mean, it depends on where you're at now and where you're starting at. And every system is different and every provider is different. If you're starting from a place that has historically always excluded family, um, then, maybe the first step is to really focus on the death notification part and making sure at least you feel good as you can feel about that piece. I think another nice way to humanify, if that's a word, I may have made that up. Um, the process without including family is the moment of silence that a lot of us have adopted at the moment that we do stop resuscitation, even if there's no family members present, is to take that moment of silent respect. And I think that's really good for the providers. And um, and that can happen it just kind of helps make this process feel um, less mechanical and work on briefing families and doing a great job with death notification. And then on a case-by-case basis, talk about bringing families in at the end of a resuscitation. Um, if you're already doing some of that, then we can maybe move earlier to having more family presence. And there's some places that I think are having family presence, interestingly, but don't necessarily include them at that moment at the very end because they haven't maybe connected those two things. Um, and then I would encourage people to have the conversations with the team, um, and with law enforcement and with medical investigators or whoever that legal authority is in your jurisdiction. Um, One thing I think is interesting with law enforcement is, I mean, I was told forever, you can't cover the body because, it's a crime scene. You have to leave this to law enforcement, and the sheet might, clothing and all this stuff is going to impact their investigation, which it was obviously true in certain circumstances. But it's amazing to me when I've actually in the real time talk to law enforcement and I'll say, we have, some, naked individual in a semi-public place and we're doing this, and I'll actually turn to them and say, you know, I have a sheet here. Would it, you know, is it okay if we cover the body or do you need to leave that for the medical investigator? It's amazing how often they're like, oh, that'd be great. Could you cover the body? Yeah, that'd be great. It's like nobody just ever asked them. And they understand when they need to do that. And I've had some times where we've, in some of these situations that are, you know, a kid on, these kids with chronic illnesses and stuff that are not an completely unexpected death. And it's like, can we cover, I'll actually, again, I'll do this if I know it's not a crime scene. I know the best I can. I'll put their favorite blankets and their stuffies and things with them before we stop the resuscitation so that I don't have to put them in an awkward position if there's junior law enforcement officer like, I don't know if I'm allowed to do this. So I'll make that decision for them in advance. Um, and I'm willing to take the heat for that if I got it wrong. But
No, absolutely, absolutely. And to your point, as we finish off, Darren, it's a hugely intimate moment and one which will stay with someone for the rest of their life. So giving people that pause, that space, that moment to say goodbye and to relate to their loved one is a powerful moment actually, and absolutely should be front of mind as you move to the different to a different phase of care, as you were saying, in a pivot in the resuscitation. Darren, listen, thank you so much for the past 45 minutes. We'll include the paper in the show notes. It's a fantastic read. I do encourage people to go away and read that from the link. Thanks again for your time, and it's just fantastic to get your lived experience and indeed your insights. So thank you.
thank you for what you do and for putting a spotlight on this topic and the other topics that you cover. So thank you. Appreciate it.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.